Okay, go ahead.
Got it. So this is the agenda, understanding diabetes. If I'm assuming even this will be useful for the people who don't have any idea about diabetes, state of diabetes in India, then social determinants of healthcare. That's why system dynamics modeling is very much useful in chronic care. Compartmental model I discussed briefly, but I will tell you why this compartmental model and why we can actually, when I went to public health professional and I told I want to use simulation, they were not convinced. When I told I am going to use compartmental model extension, which is system dynamics, and because here also we have a stock and flow diagram, then they were very much convinced. And this we already use, so you can use it. Time series versus system dynamics modeling research objective of the my. I'm again saying this is was only a small part which actually of my PhD. So research objective related to that work, research methodology, causal loop diagram. I tried to include all social determinants, and that was one of the challenge. Became very difficult to handle the model at that time. So it's also a was very good learning how much you want to include in a system dynamics model. That also you need to decide. Sometimes you try too much and then it grows out of proportion, and then so you have to think the scope of the model also. Stock and flow diagram, so, and initialization of the model, baseline behavior, and when the baseline behavior was the present state, on the basis of that model was simulated. Policy intervention, and I took some values which I actually discussed with focus group. I will be discussing how we found focus group, what we discussed in that. And then from the policy intervention, then we assumed if we are implementing these policies, these variables will be varying from here to here, from suppose point 2 to point 4 or point 3 to, and then again that was based on assumptions and inputs from the focus group, and then a result was there. The thing was there, what I concluded, one of the finding was that even we were going to implement that policy, the prevalence of diabetes was not decreasing. So it can be termed as a kind of policy paralysis. So the results were not very encouraging, means breakthrough kind of that. So first, when I presented during my PhD, people didn't find it very means significant. Then I told, even you know that the policy is not going to work is itself a finding, because you are not going to invest in that policy and a lot of money will be saved. And take home message, and then I will present the model which I and Yuan is working on for system dynamics modeling of India. Diabetes is a chronic condition that affect the body's ability to use sugar and glucose for energy. So people feel tired and many polyuria and many problems occur. Type 2 diabetes, it is called now, mellitus we have removed, because without sugar also there are certain complications. So type 2 diabetes has become a major challenge for health system around the world. The global diabetes prevalence between the age of 20 to 79 years is around 10.5. And I'm here sitting in Dubai. Here the prevalence is around 17 to 18%. And more than 550 million people are actually living with diabetes. The prevalence is expected, the world prevalence is expected to rise to 12.2 by 2045. But in UAE and in India, this prevalence is going to reach a higher figure of 20%. The global disease burden is 966 billion USD, and is projected to become 1054 billion. That's why it's imperative to investigate the state of diabetes prevalence in region where I am, both two region I'm trying to do in UAE and India. Type of diabetes, the type of diabetes, again, we were not modeling for type 1, type 2 or gestational diabetes. We were only taking type 2 diabetes. So there are three main type of diabetes, type 1, type 2 and gestational diabetes. More than that, there are other diabetes also like MODY and all. So there are 7 type of diabetes, but these three are the major. Type 1 is usually diagnosed in children and young adult. Type 2 is most common form, and gestational diabetes occur during pregnant women and usually resolved after childbirth, but it need also attention. So mostly the figure we are going to discuss, or the policy we are going to discuss, is targeted to type 2 diabetes. The role of insulin also I want to model in the future, but so many things are there. Insulin is a hormone that helps regulate blood sugar. In type 1 diabetes, the body does not produce, and but in type 2 diabetes, its functioning is not proper. The body doesn't produce enough insulin or use it effectively, which may also require insulin or other medication. Risk factor when we talk about family history, obesity, physical activity, age, poor diet are some of the risk factor of type 2 diabetes. Even pollution is risk factor of diabetes because you will develop COPD, and then you will develop asthma, then you will become physically inactive, and then diabetes will be there. So there are various pathways. The risk factor for type 1 diabetes are less well understood. Genetic and other factors are there, so that we are not taking into account. Complication, unmanaged diabetes can lead to several complications such as heart disease, stroke, kidney disease. So that's we have shown in progression of our model. Prevention and management. So you can do prevention, you can do management. So these are two policy levers. So maintaining a healthy lifestyle, including a balanced diet, regular physical activity, routine checkup can help manage or even prevent type 2 diabetes. There is a term which Jack paper actually talk about, only there I found was reversal of diabetes. So reversal of diabetes is not possible as such, but remission of diabetes is possible with medicine and all. So therapy is crucial for managing the disease. Then this whatever we think that diabetes is managed in hospital is a myth. 80% of the diabetes related management is outside the hospital. So social determinant, that's why it becomes a very beautiful system dynamics problem. So social determinant of health refer to the condition in which people are born, grow, live, work, and age, including wider set of forces and system shaping the condition of daily life. These determinants can greatly influence the risk and outcome of disease. So how to model that? That is challenge. Socioeconomic status is a problem because if a person is suppose having calorie rich diet in their childhood, that can affect their onset when they become more than 40 in the age. Income and education also decide whether how people is going to take their diabetes, how proactively they are going to participate, or how much they can afford. Access to healthcare is a major challenge in UAE also. UAE, you must be thinking why it's a challenge, because UAE population is not only Emiratis people. There are migrants, there are expats. So there is actually access to healthcare becomes a problem when you cannot afford healthcare without insurance. And many people are not in. So this is also a challenge, how to include this insurance factor into diabetes system modeling. So we are actually many things are there. Timely and appropriate healthcare can help in early diagnosis and management. That's why I told. So diagnosis and then there will be management. Before diagnosis, we can go for prevention. Cultural factor, belief, tradition, values can influence dietary choice. Some people eat red meat, or some people eat white meat. Some are means vegetarian. Some people consume more oil in their food, like South Indian people or South Asian people. So their attitude toward medical care. Some people cope with diabetes very easily because they are religious. So these factors, how to include in that? So I was facing a lot of problem in that, and still I am not able to include all factors into diabetes system only. Neighborhood and physical environment, whether there is food access is there, physical activities there, grounds are there or not. In UAE, we hardly find any open place to play, and because the weather is very harsh here. In India, the population is too much that you will not find a provision of playground in your in residential area. So that's again a problem. So both place there is no outdoor activity, but the region are different. Social and community contact, social support plays a significant role in managing chronic disease. Individuals who are isolated or lack support may find it challenging to manage their diabetes. Education, health literacy. Even I have seen many educated people, they are not health literate. No, so health literacy is poor. Health, the people who are, because diabetes, a person in the, we used to say that it is a, it's a teamwork where doctor is in code. No, there is the patient is in code. Patient need to take the charge of their diabetes management, and then they will be able to achieve milestone more easily. So education, so health education, occupation, certain occupation may involve sedentary behavior like banking, IT jobs, and all the job I do actually also involve means sedentary lifestyle, and that causes diabetes. Stress and mental health is a rising concern. Chronic stress has been linked to the onset of type 2 diabetes early, even early in 30s. Moreover, individuals with mental health disorder like depression may find it more difficult to manage their diabetes effectively. So, race and ethnicity. So Indians, there is a worldwide paradox, which actually say that the same BMI level person in Israel will be having less risk of diabetes compared to people in India having same BMI. So that's why there was a famous study of Anup Mishra, and they actually revised the BMI criteria for diabetes in India, and they make it 23. So this was 23 for South Asian it is, and for European it is something around 25, 26. So race and ethnicity also plays an important role. So you are using some model, you have to adopt it for local. So same model, system dynamics model will not be working for UAE as well as India. Health behavior, these are influenced by social factor, or example, tobacco use, alcohol consumption, and dietary pattern. And government subsidies and other thing also play a very important role in what actually people going to consume. Whenever there will be inflation, the country, the protein will be substituted by carbohydrate, and that increases the risk of diabetes in healthcare. So this is a very famous this Dahlgren and Whitehead famous rainbow model for social determinant of healthcare. And this actually concur with the thought that 80% of diabetes is actually managed outside the hospital. So that's become very important. Profile of India, I will briefly go through that, and then I will go to the model and how we did that. India is a diverse and populous country with a unique demographic profile. Population is highest in the world, 1.4 billion. Age structure, the relatively young population, but now they are aging. Even 10% of Indian are more than means aged. That is a big problem because 10% of 1.4 billion is more than the population of many countries. Urbanization, there is a growing trend of unplanned urbanization with more people moving to cities. Economic growth because health inflation will be there when people will be having means money in their pocket. But again, the same thing, this is not, this economic growth has not reached, benefit has not reached to everyone. So there will be a lot of marginalized person. Education and literacy is rising, but again, that is, there is a digital divide. There is a uh, access to higher education is limited to few people only. Healthcare system is mostly predominantly secondary and tertiary care is provided by private player, and government has very major spending of around 2% of GDP for a population of 1.4 billion. So and most of the this funding is for maternal and neonatal diseases and communicable diseases. So very less fund allocation for chronic care. And there are many success stories in India, and India, even insurance, which I was earlier talking about, after, it will be very interesting after the implementation of the Ayushman Bharat healthcare universal health insurance in India. What is its effect on actually diabetes in that country? So there are many cases, but a lot need to be done in India. This was the case where I was actually, my college was located in way back 2017. I was working there as a research scholar. So Varanasi, the ancient city in the northern part of India, it's a true representative of India because many people from different part come there because that is a holy city and religious importance. So population is also very much mixed. Though healthcare facility in city had improved in recent past, but hardly sufficient to fulfill the demand of healthcare in city. Thousands of patients from catchment area visit that city only for healthcare. Already inadequate healthcare infrastructure was in pressure, so we were thinking about how to uh, plan something for adaptive management in that city. The government and healthcare providers still use conventional method for evaluating and managing each aspect of disease separately. And these tools were not capable for addressing the dynamic complexity of diabetes, which I was talking about. So I have given you all facet of diabetes, how it looks. Now, when we will be discussing model, then many things thought will come from your mind that we have missed this, we have that, missed that. And the same problem I was also facing when I was working my PhD, and every day I was not satisfied with the model. Everything different thing I used to add, I used to present to my guide, and then they used to come up with something different. Then I used to present to some clinician, diabetologist. They used to suggest something different. The finally I settled on a model. Luckily, and I completed PhD. That model I will be showing you. There is hardly any research to estimate the prevalence of diabetes in Varanasi and surrounding area. Epidemiology of diabetes. Epidemiology is a study that often diseases occur in a different group of people and why. So for epidemiology, we can actually, this is underutilized system dynamics tool in epidemiology. Epidemiology, you can use it very frequently. It provides the key information to identify the causes of disease and to evaluate the effectiveness of preventive and therapeutic measures. Several methods are utilized in epidemiological distribution, and many determinants which I was discussing right now actually are taken care of. Epidemiology started with the famous problem of hand pump. I will not go into that detail. The major shortcoming of the prevailing model is that these models are more descriptive, less prescriptive, and system dynamics model is which is actually prescriptive model. So that's the major advantage. Hence, simulation model can be helpful in effective planning in population health. Compartmental model in epidemiology, the SIER model. Compartmental model is extension of this basic SIR model. SIES is susceptible, exposed, infectious, and recovered. These models are very good in case of disease modeling like COVID-19 and all. But again, this is descriptive. No, how policy is working and will work, whether there will be a policy paralysis or it will be effective or not. If you want to do those scenario simulation, then SIER lacks there, and then that's why compartmental model are not suitable for chronic disease such as diabetes, which is very complex. So system thinking advantages, all of you know system dynamic. That's why I will not go into that detail. It provides you a holistic perspective. It is not linear like SIER model. It involves feedback loop. Here, the beauty is you can even plan for the delayed effect. System thinking acknowledge that decision made today might have consequences that are immediately apparent. So we can actually introduce delay in our policy reaction. Interconnectedness of the factors. So these all factors, socio-economic factor and all social determinant. And even nowadays we are talking about commercial determinant of healthcare. So these all factors, and these how they are interacting with each other, how they are affecting the flow, that can be modeled in system dynamics. There are many leverage points. System thinking aims to identify area in the system where all small intervention can lead to significant change in diabetes. This might be early education about diabetes, so this becomes policy level, ensuring medical access, providing subsidy, making generic drugs compulsory, or making controlling the price of certain drugs like metformin or pioglitazone or whatever it is, or maybe making ensuring that this medicine like liraglutide, suppose this patent is expiring in this December. So then after that, it becomes available to majority of population at affordable cost. So there are many things. Structure shape behavior, because this is very famous saying in system thinking. The way a system is set up, whether it is a healthcare system, a patient daily routine, or societal norm around diet and exercise, it influences the behavior. Recognizing and adjusting this structure can lead to better diabetes outcome. Socio-cultural influences. Diabetes management is not just a medical issue; it is influenced by cultural belief. Already, I have told you around the food activity, socio-economic structure, everything. Adaptive strategies, just as the system are dynamic, they are also ever changing, and strategies to manage diabetes should be adaptable. System thinking encourages continual learning and adoption based on feedback from the system. Patient empowerment, we can recognize how patient education can affect the progression of diabetes, collaborative approaches, how there is a constructive or destructive
Dr. Mishra?
interference between this. Yes, ma'am.
I just
And
want
these
to let you
are
know that we have about 20 minutes left. So I know you want to get back on your model. So just so you know, that's how much you want to show us your model.
So research objective was research objective was to propose and use a system dynamics model for prevalence of diabetes in Varanasi. This was to test the effect of policy intervention on prevalence of diabetes using system dynamics model. Computer simulation are broadly used in healthcare, and this I will skip actually. This was how we did. Summary of the research method is focus group formulation, conceptualization of the model, and then every stage we actually have shown this model to our focus group for their validation. So causal loop diagram we prepared. I will be showing that. Then stock and flow diagram, basic the model of Professor Homer model, and on top of that we actually built initialization of model, analysis of baseline behavior, and analysis of policy intervention. So these last 5 stages were used using Vensim tool and focus group. Only whenever we wanted to build consensus, we went for a Delphi method. This was the participant group, researcher, which was I at that time, endocrinologist, cardiologist, physician, psychologist, social worker, nutritionist, and dentist. So every stakeholder was actually part of this focus group, and we took the size of 8 because there is a famous Miller's theory of 7 plus minus 2. For which actually suggests that what should be a focus group size. If it is too large, very difficult to build consensus. The focus group meeting was like this. Meeting 1 was model conceptualization. Meeting 2 was outline development. Meeting 3 was development of model. Meeting 4 was finalization of model. This was the basic model which I took from work of Homer and Jones. Actually, here it talks about recovery from undiagnosed pre-diabetes. So if there is a pre-diabetes stock in your model, then only you can think about recovery from the pre-diabetes. If you have model like normal glycemic population and then onset, and then you are going to undiagnosed diabetes, so in that case, there won't be any recovery. There will be only a possibility of remission. So that we have tried in the second model, but this was the basic model I used 5 years back for system dynamics modeling. And this is the actually your causal loop diagram, where I have tried to the red color items are actually policies. So physical activities, how environment is affecting physical activity, access to preventive care, how availability of preventive health care, how affordability of preventive health care, that also. So here actually further we can discuss about insurance role, testing from complicated diabetes. So how to detect diabetes. So here also government roles comes into picture, testing for uncomplicated diabetes, detection of uncomplicated diabetes, and testing of pre-diabetes. So these are, here we are doing diagnosis, here we are at preventive stage, availability of qualified onset of diabetes, and when you are making capacity building for diabetes actually, so then availability of qualified allied staffs, availability of qualified doctor, health insurance, government subsidies, awareness program, literacy, and availability of hospital beds. So this was there were balancing loop, some 5 balancing loop and 1 was reinforcing loop here. So what we tried to do here, this stock and flow diagram. So here the environment is one of the policy. Then testing for pre-diabetes, then availability of preventive and testing for uncomplicated diabetes, affordability of preventive healthcare, testing of diabetes, and availability of hospitalization. So this red color auxiliary variables, we took a baseline value on the basis of input from the doctors, the focus group which I discussed. So this was, suppose work schedule is like effect of work schedule on physical activity, it's a multiplier was 0.5. Suppose we absence of any information we took at 0.5, and if it is more than 0.5, then it is going toward more means physical activity, and it is going toward zero, is going less. Physical disability, and then effect of environment on physical activities, the intake of calories, exemption of the calories without active physical activities, birth rate, death rate. This we took from census data of 2011. So it was also debatable whether birth rate has decreased and death rate has increased or decreased, because that was little older data. A normal non-diabetic population, so this was for the city, and undiagnosed pre-diabetes population, these were initial values. And similarly, complicated diabetic population and undiabetic population, this we took from some survey, and where the information was not available, we took the Delphi method we used to ascertain the values. So result of this run was like undiagnosed uncomplicated diabetes was increasing, and then it was decreasing, and it's follow like a bell-shaped curve. Undiagnosed complicated diabetes also increasing and decreasing. So highlight what prevalence of complicated and uncomplicated diabetes by year 2000 will be 0.52 million in the city which we were discussing, and at present growth rate of 1.19, the population of Varanasi will be 1.46 by the 2030. We actually made this. This data gives us the prevalence of diabetes by 2030 was staggering 35.64. It was actually beyond the assumption, which wild guesses of the doctors, which were they were saying that it should be around 30% by 2030. Now it was around 35.64. Then we thought about if we implement certain policies, like we start providing healthcare finances, we build up hospitals, we actually provide provisions for playgrounds, and many things. We actually provide allied healthcare professionals, detection we facilitate, management we facilitate. Then what will be the scenario? So for that baseline value, the targeted value as the combined effect of these all policy measures, we took that the environmental condition we thought will be increasing by 50% to 80%, but believe me, that's not going to be true, because from this now 5 days situation had even worsened. So from 50% it has become something like 45. Testing of pre-diabetes 20% was there. We testing it can be increased and can be made to 100% also. Availability of preventive care 50% was initial value, targeted value can be 80%. So this way we took the targeted values and then we tried to simulate again. And then this was that in 2032 it was peaking, not in 2030. And the same, so by policy, one of the influence was there. If we are implementing policy measures, the progression of diabetes can be delayed, but seeing the profile of the population of the city, and there is one famous saying about Varanasi also. People come there to die actually, because they find that if they will be dying in that city, they will go to heaven. So that's why the portion or proportion of older population is higher in that city. So what conclusion we made at the result of simulation show the prevalence of complicated and uncomplicated diabetes by 2000 will be this 0.52 at present growth rate. The population and the prevalence will be in 2030 will be 35.64. Total population suffering from diabetes will increase irrespective of the policy measures. So this result actually I presented, the people didn't like that. Then I don't know even 2 years it is getting delayed. And this is also one of the findings that even you are doing this much, that is not sufficient. Hence, policymakers need to tackle diabetes at a pre-diabetes stage. So only thing remaining is target diabetes at pre-diabetes stage. And pre-diabetes stage you are targeting, then effect can come. Again, the thing is government spending is measured, then they can go for only pre-diabetes stage, and later they can leave it for private players. The government should work in direction of bringing the majority of population under medical insurance. That was one finding we actually got, to reduce the risk of poverty due to diabetes. The future direction at that time was system dynamics modeling as a case organization. What was lacking here? Incorporate more social determinant of healthcare in model. Many things we actually missed, like inflation and healthcare financing. Include commercial determinant of diabetes in model, like people are using packaged foods are there, and packaged foods are there, people use um, preservatives and other things to increase the shelf life. So those are called commercial determinants. So how to incorporate those in, develop a simulator for policy making for diabetes management. And that I'm working with Ivan to try to develop a simulator for policy making for diabetes management, and develop a user-friendly web application that can be used for public health policymaker. And similar tool we are trying to develop for UAE. And this is the stock and flow diagram which we are working right now. In UAE, we are not able to find out the data for how to do for pre-diabetes, but in this model we are actually trying to include effect of obesity and poor diet and sedentary lifestyle, effect of healthcare availability in UAE, normal life expectancy without diabetes. And then this is the model again. We are thinking in some and then trying to incorporate. So even a little simple model, but we will try to test it. So this still we are working, and maybe in future sometime I will be sharing it what we model for you. Thank you. So this was from my side. If you have any question, you can ask me, or any input you can give so that I can make it better.
Thank you very much for that presentation. I just want to let you know that Jack Homer had to drop off, but he extends his apologies for having to leave. But I think he is definitely a good person to chat with and get some feedback. So I said I would ask if you would share your slides so I can send them to him, and he can give you some specific feedback, maybe over email. Is that okay with you?
Sure. Sure, okay. Sure. That's so.
Cool.
I can stop sharing?
Yeah, I think so. I mean, does anyone have any questions or feedback, comments?
Do you want us to raise our hands, or do you want just to kind of have an open forum?
I think it can be open. Yeah, I mean, anyone can just unmute as they would like.
So perhaps I can start. Thank you very much for the presentation. Very insightful. I was wondering, what I hear is that here I live in the Netherlands, that lifestyle is also becoming an issue in fighting diabetes, and where is that also the case in India, the model you developed, and where would that then be positioned in your model?
Yes, lifestyle actually here in India and UAE also, people start early for their offices and they come home late. So they don't find even the morning time or evening time for doing some outdoor activities. And otherwise, the day is very tough. Means weather is very harsh here in UAE. Similarly, in India, you will not find the place for doing outdoor activities. So that's why the government came up with one guideline recently in India, that school will not be school have to make mandatory, means sports ground and sports hours in their their colleges. So that's for children. But what about grown people over the age of 40s? So if this corporate come up with gyms during where people can go and do some physical activities, that can actually affect. So yes, of course, in India, diet is also not good because a lot of carbohydrate component is there, and physical activity with economic growth is decreasing in our part of India.
Thank you. And maybe as a follow-up question, was your primary goal to make a point estimation of diabetes development over time, or did you more have a mind to have a correct description of the systems influencing diabetes? So because you end with a very strict percentage, and
yes,
so
that we were able to do. That's a point estimate, but the range was there. Actually, the thing is, it was between around something for 30 to 40%. But the thing is, we tried to the PhD thesis was about strategic planning for diabetes. So we wanted to know a number so that we can do reverse calculation and suggest the city planners about the number of beds should be there for diabetic people, or a special type of OPD should be there for diabetes people. So thankfully, there's some hospital started making a Thursday or Friday as a day for, especially for diabetes OPD clinic, and then everyone know that's very lucrative also, because once a diabetic patient comes to your office cardiology or whatever diabetes, then they will keep coming to. They're returning again the recurring source of income. So that's why we were actually first we actually using system dynamics we came up with the prevalence. Then we multiplied it with the number of the population. Then we multiplied it and calculated how a number of beds required only for diabetes, and then we went for the facility planning problem, then vehicle routing problem. So this was actually system dynamics was the starting point for the thesis. So that's why, and best thing is here, you only not need to have numerical data. Even you can have the qualitative data, and using qualitative as well as quantitative data, you can model it at the same time. So that was helpful, because whenever you try to model a regression or whatever, either you go for quantitative data only. So here quantitative as well as qualitative data you can incorporate.
Thank you.
I have a couple of questions. I tend to talk too much in these things, so I didn't want to jump in too quickly, but I'm really curious about how you validated the feedback structures themselves. And so because they really do drive what you're finding. The fact that your findings were sort of less dramatic impacts of policy interventions makes me wonder, how did you go about building confidence that you had the feedback structure, fundamental feedbacks created working? So that's just one question. And I have another, but I'll yield the floor before I ask my other one in case of.
So yeah, first the focus group we created, they were not ever aware about system dynamics at all. So first we took a workshop of system thinking to them so that they get some idea. Then we actually give a workshop them what is actually linear and how everything is not linear. No, there are feedback loops which exist and effects also. So whatever we actually, on the basis of literature, we suggested that this would be the feedback loop and all. We actually get it validated from the focus group, that what you think, this is the same you think, or you want me to adjust. So this way we try to validate it.
It seems like, though, you had mostly negative feedback, balancing feedback loops, which would suggest strong policy resistance. We know that's commonly the case.
Yes.
But what you're really looking for is the type of loop that can start things moving in a desirable direction, which would tend to be those that can reinforce.
So
I'm curious about that, just that it came out so many of them were that way. You must have been looking for the interjection of new loops, perhaps, that actually would feed on themselves. You know, whatever. I'm that's all I'm going to say. I know these are very complicated and complex issues.
yeah, it's very. So luckily or unluckily, it didn't came. And the thing is, the 5 years, the data I compare, it is almost the same situation persists. The prevalence has even there is universal health coverage in India. Diabetes is also covered in that insurance. Lot of clinic is coming in Varanasi. So if you think what we suggested in policy, the many things are happening, but the prevalence has increased. It has not decreased in that city. So because the factors which are contributing to growth are stronger, I think that then the which are actually negating it. So very interesting case, but this we found of this model.
Question. How did you go about gaining fidelity in the parameters of your model? For instance, their values.
The values.
Yes.
So values, again, I'm saying the values were collected. See, wherever it is birth rate or death rate, this data was taken from census. And wherever the missing data was there, the extrapolation and then averaging out was done. Wherever data was not there, we asked focus group to provide a qualitative estimate. So on a scale of 1 to 10 or on a scale of 1 to 100, wherever it was applicable. So they gave the rating. And then we again applied them with what we are expecting as a policies. These all are. And then what you think will be the values if these all are implemented. So they again come up with that value. So this way we found that. If there is another better method, then I will be happy to learn actually.
Yeah, so I'm going to try to speak to that. But I know there's people who are way beyond my caliber in this chat who can speak more to that. So when calibrating your models, of course, calibrating data to data is always a preferred method, whether I'm trying to think of a few different methods offhand. MCMC, I'm trying to, what's the hill climbing method called again? It starts with a P. Wayne, do you remember? It's okay if anyone recalls. But regardless for a second, you know, you have assumed parameters, which you can definitely get some of them, and then calibrate the parameters that are unknown and you want to tune your model towards. And if you have enough data, not just the exogenous data of, let's say, of birth rate and or population growth to your model, then you can calibrate to part of that data and then see the results are validated with the remaining data set. But those are just some initial thoughts.
Yeah. Actually, that's the right approach. It should be. But the problem was we're not getting data, and mostly secondary studies, those were not representative of the city, because the city is very less studies were there from that city. So these were the certain challenges. But of course, if we get data, so part of data we can use to run the model, and then part of data we can use to validate that model. So if have a means 50 year of data or something, then again one of the thing is historic data. If we are getting that, may not be true representative of the future. In case of diabetes, the way, suppose anything can actually change the healthcare landscape. Suppose this ChatGPT comes. So ChatGPT can affect diabetes management. People will start doing self-medication. And when they will be start doing self-medication, they will come to clinic or formal setting only after then things get worsened. And in that case, the progression will be suddenly high. So many thing affects. So future is not always same in case of healthcare. So using historical data to calibrate model and then validate it and then doing it's a tricky I find. But of course, if data is there and we can means day-wise data or something like that, we can calibrate, then that is the best stage.
So I think I have 2 or 3 follow-ups to that.
Sure.
One would be definitely, getting the perfect data stream for your model may not exist or is not applicable. I know Jack Homer did a diabetes model for the US and probably adapted his first iteration of his model. My first thought is if there's proxies for some of this data, for instance, those who maybe go to a health clinic to represent a larger region, they may have better records. Of course, maybe it's not along the time domain that you want. The second overall thought I have is the sensitivity of your model results. And in Vinsum, what you can do nowadays, I believe, and I'm looking for
yes, I have done sensitivity analysis, but I am not included in that.
Okay.
So that should be the, yes, of course. That gives more reliability for your data. So more findings, sorry.
I wonder
more
if we could take a break and go back to our administrative task. And then if you're willing, if you have time, and some people wish to stay and ask additional questions or make additional comments, that would give us a chance as a group before we lose everybody.
Yeah, I just need a few minutes, but thank you everyone for sharing comments and thoughts with Dr. Mishra, and thank you very much for your presentation today. It is recorded, so if you want to share it with others, it'll be available soon.
Sure.
So I'm going to stop the recording. And